Good afternoon, and welcome to the Wilmot Cancer Institute Community Conversations on Cancer series, sponsored by the Office of Community Outreach and Engagement and its Community Action Council. I'm Dr. Candice Lucas, and it is my pleasure to introduce today's topic and our phenomenal speakers. Community Conversations on Cancer is an educational series designed to inform, educate, and disseminate best practices in cancer research, clinical care, and community engagement. Through this format, evidence-based perspectives on the continuum of cancer care and research are highlighted from both the academic and community perspectives. Over the course of the series, topics will address the social determinants of health, improving cancer care delivery, and promoting health equity across our 27-county catchment area. This live event has been approved for 1 AMA PRA Category 1 credit and 1 contact hour for social workers by the University of Rochester School of Medicine and Dentistry, accredited by the Accreditation Council for Continuing Medical Education. In recognition of June as National Cancer Survivor Month, our discussion is titled Celebrating More Birthdays, Cancer Survivorship in Older Adults. We will hear from Dr. Supriya Mohile and Mr. Jason Coleman. Dr. Mohile is the Philip and Marilyn Wareheim Professor of Medicine and Surgery at the Wilmot Cancer Institute. She is a board-certified geriatrician and oncologist and is director of the Geriatric Oncology Research Group. Dr. Mohile's research interests include the evaluation of patterns of care, health outcomes, and quality of life related to treatment for systemic cancer in older adults. She is also working to develop clinical trials for older adults with cancer and to identify interventions to reduce treatment morbidity. Mr. Coleman is the manager of Cancer Support Strategic Partnership at the American Cancer Society, where he represents Western New York in the Cancer Control Division. Mr. Coleman also co-leads the Community Cancer Action Council's Access to Cancer Care Working Group. He is a strategic partner to the Wilmot Cancer Institute, as well as other health systems, federally qualified health centers, insurers, and coalitions throughout our region. I will be your facilitator for this session's Q&A segment. Throughout the presentations, please feel free to enter any questions in the Q&A box located at the bottom of your screen. If you would like a question directed specifically to one of our speakers, please include the speaker's name in the question. So now, without further ado, I will turn it over to Dr. Mohile.
Thank you very much. While I share my slides, I'll just talk about how wonderful it is to be here today and really discuss things with all of you. I've lived in Rochester growing up since I was 12 years old, and I'm really tied to this community. I did go off to school elsewhere, but when I came back, I started working at Wilmot in 2007, and I've been here ever since. And one of my major goals is really to improve outcomes and care delivery of all patients with cancer in our catchment area. One of my roles is as the Cancer Prevention and Control Program leader. And so I guide not only the research for older adults, but also for all cancer patients in terms of survivorship. And today I'll focus on older adults. That is one of my expertise. And it's really wonderful to be invited to give this talk today and also to partner with the American Cancer Society to discuss these issues. And I am really happy to take questions. I'm going to go through my slides to allow Mr. Coleman to have enough time. And I'm really hope we'll have time for a discussion at the end. So why is geriatric oncology important? I think when we're thinking about cancer, we have to remember that age is the strongest risk factor for cancer. What that means is that the majority of patients with cancer are older. 60% of patients with cancer are older. And as the population ages, 70% of cancer survivors will be older than the age of 65, with a growing proportion of patients in their late 70s and 80s. Now, with advances in care for heart diseases and diabetes, we're seeing patients and people live longer and longer in our community and really live fulfilling and independent lives. we have to do the same thing for cancer, in that we're addressing cancer, treating cancer, and addressing survivorship in this population, because this is not an underrepresented group of patients with cancer. It is the majority of patients with cancer. From the slide, we can see that the demographics are really increasing, and you can see this sort of top bluish color of how the gap, it's really growing for patients over the age of 85, and the purple being patients over the age of 75. And so I'll talk today about the survivorship needs of older adults with cancer. I'll talk about using a care model that really works for older adults, and this is called geriatric assessment. And geriatric assessment is really just a complicated way of saying that we really ask patients about their health status and ask them how they're doing in terms of quality of life, psychological health, functional health, and use that information to guide care delivery. And I'll explain that more in that talk, and also explain how the geriatric assessment can improve outcomes. So again, taking this back to patients and families, this was one of my patients and his daughter, who we cared for in our clinic. And this patient, during his course of treatment, needed some help with daily activities, had some comorbidities, had very mild cognitive impairment, some social support limitations because he lived alone with family support, had transportation issues because he required assistance coming to the clinic, was on several medications. And while he wasn't frail at the time, the treatment caused him to feel more fatigued and have some more physical performance issues.
Dr. Mohile, I apologize for interrupting, but we're not seeing your slides.
Oh, I don't know why. Let me look at what's happening. I was flipping through them. Sorry, we did practice this. Let me see. Oh, let me share again. Now you see them.
Now we see them. Thank you.
Okay, thank you for letting me know. I thought it was going. Hold on, let me just do slideshow. Here we go. You didn't miss anything. So here's the slide. Do you see them now?
Yes, we can see them.
Okay, good. All right, good. So here is where I was. So we're really talking about the medical issues that older adults have when they come to the clinic. And they really, so when older adults come to see me, they're focused on the cancer, which is the most important problem that we're addressing. However, all of these other issues are important in the decision-making from cancer and in cancer survivorship, because it affects the overall quality of life that patients have. And these are concerns for patients and their families. Unfortunately, patients like this one do not participate often in clinical trials, because our clinical trials are not always designed for older adults. They're designed for the middle age group of patients. And so they often exclude patients with these medical problems. And what does this mean for survivorship? It means that when we're providing treatment plans for older adults, we're sometimes overreaching with some of the treatment plans or underreaching, because we don't know that right time point for what the right kind of plan is for the patient sitting in front of us. And then for patients who may receive a treatment that may be not physiologically beneficial to them, they may have toxicities that lead to significant survivorship issues. We know that there are aging-related concerns and conditions that older cancer patients had. I mentioned my patient there that had those issues and concerns. We did some analyses looking at a population-based data set, and we looked at the prevalence of things like functional impairments, what we call geriatric syndromes, which are things like falls or cognitive issues, and vulnerability and frailty, which are measured in measured as disability or comorbidities. So what vulnerability and frailty is characteristics that lead to increased risk or adverse outcomes for older adults with cancer. And what we found was cancer survivors had a higher prevalence of these issues than patients without cancer. And this is likely a consequence of both treatment and both cancer and its treatment. We have a clinic in our here in Rochester that's at Highland Hospital, but as part of the Wilmot Cancer Institute, where we provide care for older adults with cancer and cancer survivors. And we used data from that clinic to also show that the number of symptoms that a patient has leads to functional consequences, meaning the more symptom burden, the more that an older adult can't do what he or she wants to do, and it compromises independence. And we looked at things like physical performance, ability to take care of oneself in their home, ability to go out into the community, and falls. And so we need to do a better job of thinking about toxicity and symptoms after treatment in order to preserve function and independence. We also know from other literature from colleagues that there's a high prevalence of unmet social support needs in older patients with cancer. This is data from the University of Alabama, and they have a large catchment area of patients who are very diverse. And what they showed in their cancer survivors was that 2/3 of them reported as having at least one need. And patients who are not white, not married, or had a high symptom burden were at the greatest risk of having unmet social support needs. When we think about cancer and its impact on the aging trajectory, and this I would say includes both cancer and cancer treatment, we know that there are some patients who are going through their normal aging process. And we know that, I'm just going to put all these on, that when we provide cancer, when someone gets cancer or has cancer treatment, they may experience more functional decline. And this may parallel what happens with normal aging, but happen at a lower point for that patient, meaning maybe someone was able to go to the grocery store and now they're not. But over time, as they receive cancer treatment, the deficit's about the same as they would have had if they were on the normal aging trajectory. And maybe they're only losing just a little bit of function rather than a lot more. We also know that there's people who are subjected to accelerated aging, meaning that they start from a lower point of function when they receive treatment, and then the deficits over time and impact on their function is larger over time due to treatment. And so these are the most vulnerable patients for which we need interventions for, and for whom after treatment may need a lot of support to get patients back to where they were, because the consequences of losing function are greater in this population. This data is from a group from City of Hope that looks at resilience. So they studied patients with breast cancer, older adults with breast cancer who received chemotherapy, and found that after chemotherapy, about 42%, so this is the prevalence in red here, had functional decline at the end of treatment. And then when they looked 6 months later, so this is 6 months after finishing chemotherapy, the majority of them, so in this red box, returned to baseline. So about 47% came back, but about 53% did not return to their baseline function. So we're seeing functional consequences of treatment over time after completing curative intent treatment. And this is really important for older cancer survivors, because function is such an important issue. And when we talk to our older adults in clinic, that's one of the most important outcomes for them, is to return back to baseline function. There was an Institute of Medicine report called Cancer Care System in Crisis. And what they showed was that 60% of cancer survivors are older. Cancer is one problem among many, as I've shown with some of the previous slides. But unfortunately, there's limited but growing evidence on care for older adults. The workforce has little geriatrics training, and the support for caregivers is lacking. And so this is a real crisis for our care delivery system. There's a growing number of older cancer survivors, and yet many clinicians don't have a background in taking care of older adults, despite this growing number. One of the gaps that we see for cancer survivorship is the need for improved survivorship care. There is a program or clinical tool called survivorship care plans, which have been advocated as a tool to communicate survivorship care needs at the completion of cancer treatment. And what this tool does is it helps people get off from the time period of being on treatment to off into survivorship, and provides care coordination models to connect clinicians and patients. But when we look at older adults who are finishing treatment, many of them don't have communication about survivorship. This is a study that actually talked to patients, and many said they didn't even know there was a thing called survivorship meetings or plans. Other people said they received a lot of paper related information, but there was not good interaction or communication about what each of the issues could help with, that there was lots of recommendations for improvement, and that PCP suggested better communication. And I know Mr. Coleman will be talking about PCPs and communication. We did a report from the Cancer and Aging Research Group, which is a national group that really focuses on older adults. And here's something that we thought should be discussed during survivorship. Patients and caregivers are really a team. Care plans should be developed with interdisciplinary professional teams carrying out the plan. Goals should be tracked. And if there's changes, those changes should come back to the survivorship team to make sure the needs of the patients are addressed. So as I mentioned, geriatric assessment could help with care delivery models. Geriatric assessment helps capture information about function, physical performance, comorbidities, cognition, nutrition, psychological status, and social support. And we know that geriatric assessment is listed in guidelines as an important tool to use for older adults receiving chemotherapy because it provides clinicians with information that can really help guide care plans. And many of us at Wilmot Cancer Institute were authors on this guideline and helped guide these national guidelines. In our clinics, we developed a care plan model that we use in our geriatric oncology clinics. So we assess each of these aging-related domains on the left here with tools that we know help us identify issues such as functional, patient-reported outcomes for function, physical performance tests, and cognition tests. And if there are concerns on those tests, we implement care processes. So for example, if an older adult has falls from chemotherapy, we institute plans like physical therapy and occupational therapy. And we do this for each of the geriatric domains. And here's an example of what we do for physical performance. We assess falls, we do a test for physical performance. And then over time, we continue to assess this while people are in treatment. And after treatment, during or after treatment to improve outcomes, we'll institute care processes. We know that will help from the geriatrics literature. We know that geriatric assessment also improves patient and caregiver communication. Patients and caregivers are concerned about things like falls and memory. And when we do a geriatric assessment, it opens up a conversation about things that could be of concern and allows us to intervene or provide good support for those issues. There are many studies across the country, including several that we've done here in Rochester, that show that geriatric assessment can decrease toxicity from treatment, increase compliance or adherence to different treatments, improve quality of life, and prevent people from going to the hospital. So we know that geriatric assessment could also help. So we think that geriatric assessment can also help with survivorship. I also feel that we need to ask patients how they're doing in terms of symptoms. So a geriatric assessment can help reduce symptoms that patients feel, in addition to toxicities that the clinicians measure. So we have evaluated a patient-reported outcome tool, and we know that when patients tell us they have side effects and symptoms, and we employ a geriatric assessment, the patients that get the geriatric assessment have less overall symptoms. And this is because the geriatric assessment helps guide communication about concerns that the patient has. We are looking more and more at care coordination for older cancer survivors, and there are many, many clinicians that are involved in improving survivorship care, with the core of the team being the patient, the caregiver, and friends, family, and community. And what we need is a guide to help know which patient needs what clinician and how to bring those services to the patients. We also know that geriatric assessment geriatrics expertise is not available in most oncology clinics in the United States. We have a robust program here at Wilmot, and we're helping to teach others nationally. In fact, only 37% of community oncologists have geriatrics available to them in their clinic. And so it's actually a low percentage of community oncology clinics that have access to geriatricians. If there isn't geriatrics expertise, we would hope that oncologists can provide that expertise, oncology clinicians. But even oncology clinicians, both oncologists and advanced practice practitioners, don't always feel confident about helping older adults return to baseline function. They don't always have knowledge about geriatric assessment. And so one of the reasons I come to present to the community is to provide knowledge in the hands of patients and community members so they can ask about these kinds of tools from their oncologists and clinicians and primary care doctors, and that these would be more widely available if they're asked for. We also know that there are different perceptions of care coordination among older cancer survivors, and this can be dependent on the type of cancer somebody has. So for example, in this study, patients with melanoma had lower care coordination than other patients if you compare it to patients with breast cancer or prostate cancer. And so I think rare diseases need more specialists involved and personal doctors needing to be more informed and up to date. As we move forward, the research goals are that we try to enroll older adults onto clinical trials, that we really understand better how cancer and treatment interact with aging, that we learn from existing research that's already conducted so that we're not repeating ourselves as we do new studies, that we partner with the community and with stakeholders, and that we really consider community settings and cost. I partner quite a bit with patients and caregivers. We have a national board that's here where these wonderful people help guide our research. And Dr. Gilmore, who's an investigator here in Rochester, wrote a paper about partnering with community, with patients in the community and advocates to help guide research. We also have a community advisory board that we've developed in collaboration with COE, Community Outreach and Engagement with Wilmot. And if there are those out there in the community who wish to partner with us on our CAB or Community Advisory Board, please let us know. As we move forward, we're now looking specifically at geriatric assessment improving function in cancer survivors. We just got a new grant that provides funding from the government for us to look at this. And I'm partnering with Dr. Michelle Janelsons and Karen Muschin, who are colleagues here, to really look at both cognitive and physical function and be able to provide the care models I've described today so that this is adopted by more oncology programs across the country. Again, we have our clinic here, so we are doing this here already. And if you have loved ones who need to be seen, we are able to see them in our geriatric oncology clinic. Patients from all over the catchment area, and this is a map of our catchment area at Wilmot, are referred to our clinics and will come, and we do have telehealth availability for our clinic. So I'll end. This is one of my mentors, Dr. Huria, who passed away from a car accident a few years ago. So I always honor her at the end of these kinds of talks. And she taught me that even as we embrace new and exciting drugs and technologies, the time-honored medical tradition of compassion and active listening is the core of what we do. So thank you very much. And I will stop sharing so we can connect back. And I will hand it over, I think, to Mr. Coleman, right?
Yes, thank you, Dr. Mohile. Wonderful presentation. And Mr. Coleman?
Perfect. Let me pull up my slides here. I'll share my screen.
And perfect. We can see your slides.
Wonderful. So I'm Jason Coleman. As mentioned previously, I'm with the American Cancer Society based here in Western New York. I've been with the society for about 13 years and have always worked in cancer control and patient support. And over the years, I've had the pleasure of working with our friends at the Wilmot Cancer Center and University of Rochester Medical Center through our Hope Lodge operation, which receives some financial support from Wilmot Cancer Institute, as well as numerous other projects in the community. So we value that collaboration and that friendship and that partnership around important topics such as the one we're talking about today, cancer survivorship. slide is.
I'm a mother of 2 wonderful children, and I'm a wife. And 12 years ago, I was really uncertain of the future. Now I have something to live for. My name is Vanessa Ramirez, and I was your regular 23-year-old college student until I was diagnosed with ovarian cancer. I don't think people realize the importance of cancer funding and how many lives have been saved just by getting early detection. I'm heading to a monthly meeting, and this is actually the event that got me started advocating with the American Cancer Society. I feel that my advocacy efforts saved coverage for many other people out there. I have the opportunity to work with lawmakers that will change our policies. I'm really working on getting our government to provide more access to cancer screenings and cancer treatment. I've become very passionate because I don't want my daughter or my son having to sit here and possibly talk about their story with cancer. I don't think I would have ever imagined that my life would have turned out this beautiful.
So I share that video just to highlight, there's over 16 million Vanessas in the United States that are cancer survivors, and every one of these tells a story that's unique and traumatic and impactful. And sometimes when we talk about the statistics and these numbers, it's easy to kind of overlook the individual stories, the lives that are impacted by those words, you have cancer. So, playing off some of the information that Dr. Mohile just shared with you, cancer treatment is much better, and it's getting better all the time through research, such as the research being done at Wilmot and other great institutions across our country. So we're going to see more survivors and addressing more survivor issues in the years to come, and that's a good thing. That's a good problem for us to figure out together as to how we can support these survivors in their survivorship journey and address some of the topics that Dr. Mohile brought up in her presentation. Whoop! I didn't want to play that again. What we're looking at in this is the breakdown of the map across the United States. I did highlight the total of 16 million. It's a little bit small, and I apologize for that, but you can see in New York we have close to 2 million or 1.5 million cancer survivors. And in the upper right hand corner you can see the breakdown by sites in the body. And you can see that as of 2019 for males, it was prostate cancer, colorectal cancer, melanoma, and bladder cancer as the #1 affliction of cancer survivors, and females being breast, uterine cancer, colorectal, and thyroid cancer. And as you can see, the projections as for the year 2030 shown in the table below, those numbers are going to go up, again, attributed to many of the things I pointed out earlier. Our goal at the American Cancer Society through survivorship is to provide a robust compendium of resources for our survivors and our caregivers. We have information. I've put the hot link in this presentation for our website. All of the resources that I'm going to be talking about this morning, or this afternoon rather, are going to be housed at our cancer.org website. So our goals at the American Cancer Society are to improve the future of cancer survivorship and the quality of care or quality of life of cancer survivors as they transition from treatment and into recovery. As you heard in Vanessa's story, cancer can be a very traumatizing and life-changing event for patients, and life is different life is different once you've heard those words and have gone through cancer treatment, and are at the precipice of your future. And that future may look different than how you envisioned it. So the more resources we can provide, the more connectivity in community. I really enjoyed Dr. Mohile's slide on that social component, and we're going to talk a little bit more about that and how the American Cancer Society is working very diligently to facilitate that community connectivity to for our survivors and our caregivers, so that they can find support in that shared life experience in their days to come. This is an example of our resource landing page at cancer.org, and you can see some of the topics that are covered, such as coping and living well during cancer treatment, living well after cancer treatment, the long-term health concerns for cancer survivors, you know, the numbers, such as I just shared, survivorship videos, and then a compendium of online resources as well, to include the Cancer Survivors Network and our Reach to Recovery website and iPhone app. We also have the National Cancer Survivorship Research Center. It's the product of a 5-year cooperative agreement with the Centers for Disease Control and the American Cancer Society, which houses additional resources that are available through links at cancer.org for patients to peruse and find resources that are useful to them. Dr. Mohile talked about some grant opportunities. The American Cancer Society is also in the process of applying for a current grant for caregivers, and some resources around that, specific to some live support services as well as some virtual. So more to come on that. But you know, I encourage you to check our cancer.org website and view the survivorship tab, because the information there is there's quite a lot. There's more than I can cover in a 15-minute discussion here today. So I encourage you to take a look at that and see what resources are available. You know, Dr. Mohile also pointed to some of these things, the patient concerns that face survivorship, you know, managing that healthcare compendium with their primary care provider. I love the highlighting of the survivorship care plans to get that cohesive integration between primary care and specialty care. I think what we have noticed is that patients have a tendency to lean towards their oncology specialists for their continuation of care, because that specialist was at their side throughout their treatment, so they feel that bond and that personal connection. But we have to really leverage the power of our care community with our cancer survivors to leverage that relationship with the primary care provider, so that we provide them the tools needed to manage that patient in their survivorship journey, and really find that balance, right, between the oncology and the primary care care plan, so that there's a delegation of sorts and an agreement between those providers as to who's going to take care of what. That anxiety that goes along with survivorship, that I think every cancer survivor deals with to certain extents, is my cancer going to come back? I have a pain and an ache. Does, you know, we automatically go to that dark place where we think of the worst. But you know, that's a result of the post-traumatic stress disorder that I think we've all experienced going through cancer treatment. You know, what are those long-term effects of treatment that are going to plague me? I saw Dr. Mohile's slide on accelerated decline during the geriatric years post cancer treatment, and that's certainly a real consideration and a real concern. You know, financial fallout, managing those bills that accumulated during cancer treatment. You know, sometimes those keep coming. And what's my new normal? What types of side effects are going to stick with me? You know, sometimes the reality of cancer treatment is that some changes to your physical function may be here to stay, and that's a new normal that we have to, you know, that can affect our psyche. And then are there secondary cancers that that we may be concerned about as well? So these are all things that fall into that bucket of survivorship that we really need to help these patients with. I put up this slide because at the American Cancer Society, we feel very strongly and are very active regarding access to care. And access to care has a big impact on survivorship. Those things are interrelated. And you can see in this example using colorectal cancer, people that don't have insurance or access to health care usually have poorer outcomes, generally speaking, versus patients that are well insured and take advantage of primary care and leverage primary care for prevention. So at the American Cancer Society, you heard Vanessa, again, going back to her earlier video and her example of her involvement with ACS CAN, which is the Cancer Action Network. Cancer Action Network is our sister organization that handles policy issues, really pushing that access to care. Well-insured patient populations that use primary care, they don't show up at the emergency room symptomatic, uninsured, with late-stage cancer diagnoses, to really shift that upstream so that we can prevent more cancer as opposed to treating more late-stage cancer. And I you know, partnerships like we have with Wilmot and the University of Rochester Medical Center are looking very strongly towards these issues in various forms as to how we can work together to change the cancer landscape and ultimately have more survivors, right? And less mortality due to cancer. Additional resources that we have for our providers and clinicians are also housed at this cancer.org website. We have robust information for Cancer Survivorship e-learning series for providers, you know, tips to measure program impacts, the National Cancer Survivorship Resource Toolkit for implementing survivorship care plans and guideline recommendations, as well as an app, right? We have apps for everything. The American Cancer Society is no different. We have an app for providers to access on their phones to ease that availability of these resources for them to utilize and leverage in their practices. And then also, you know, Vanessa's story about the Cancer Action Network and her involvement, we really work with our survivorship community for that community connection side of things, you know, to connect them to other survivors through our event portfolio, such as the Relay for Life, which happens in communities all across Western New York and the nation, as well as our Making Strides Against Breast Cancer walks in October, numerous volunteer opportunities. As a volunteer-driven organization, the American Cancer Society works very closely with our volunteer base to be in our communities and disseminate mission messages around prevention and early detection, as well as operation of Hope Lodges and many other programs at the American Cancer Society. And we value their contribution to our mission goals. You know, sometimes our most valuable resource is our time, right? And these volunteers give a lot. Also, the American Cancer Society Cancer Action Network, which I mentioned, you know, pertaining to Vanessa's story. That's our policy arm. And we have a group of volunteers that go to Albany every year that talk to our lawmakers to let them know of issues specific to their community around both prevention and early detection and treatment. And, making those issues a priority as our policymakers structure programs to address these issues. We want our voices heard, and our volunteers speak loud and clear, and we value their contribution. Finally, additional ACS online resources. We do have the National Cancer Information Center that's available 24 hours a day, 7 days a week. We have the Reach to Recovery website, as well as an app. And then the Cancer Survivors Network, where cancer survivors can meet in a virtual space and discuss their shared experience and bond over that. I often laugh at myself why I like YouTube so much, because I can go on YouTube and I can find somebody just like myself that has my lawnmower disassembled in the garage and my toolbox that's missing half my sockets, just like that guy in the video. And I feel like I'm there with him, fixing that mower, and I feel empowered to fix my mower myself. And I think a lot of that is very analogous to what I see with the Cancer Survivors Network, that, that shared experience, that collective optimism and hope, and that discussion of issues pertaining to survivorship is an important experience, and one that we work very hard to facilitate at the American Cancer Society. So I think that's my last slide. So with that, I'll turn it back over to Candice, and I think we're going to open it up for a question and answer period.
Thank you so much, Jason and Dr. Mohile. This was a fantastic presentation from both of you. So we do have a question in the Q&A box, and I also got a few that came in through chat. So we'll just kick it off. And I think this first one is for you, Dr. Mohile. What services are offered for older adults in regards to survivorship once treatment is complete?
So that's a great question. I want to apologize again. I now noticed that I had a bunch of chat things coming to me about my slides. So I had no idea you couldn't see them. So thank you, Candice, for letting me know. But I think it went okay. So yeah, I think there are great services as the ones that Jason mentioned too. So there are foundations like American Cancer Society that are doing a lot in the community. I think the first step is really talking to your clinician. So when you get cancer treatment, obviously there's usually one person in charge, and that's often an oncologist, but could be a surgeon or radiation doctor, depending on what kind of cancer treatment you're getting. And once you're done with treatment, asking those questions about long-term survivorship and what the impact of those treatments are is important. And then having a conversation and making sure that's communicated to the primary health care doctor is important. And then as you go forward, thinking about resources, I like to think about it in terms of symptoms, function, other medical problems, medicines that people are on, and then really break it down into small pieces about what we could intervene on. So sometimes there are medical resources. In my clinic, I have a physical therapist, an occupational therapist, a nutritionist, and a social worker who are seeing patients alongside the clinicians, both myself, my colleague oncologists, and advanced practice providers. And they provide a lot of input in the clinic about trying to exercise, what is the healthy management for weight, how does someone get back to doing things that they were doing and loving before, if there are financial difficulties, making sure that we are addressing those. For older adults, often we're talking about living situation. Is it safe for someone to be in the home? Do they need more care in the home? How can we do that by preserving independence the most? And our social worker has a lot of resources like Lifespan in the community that can help us with that. For physical function, we rely on our programs in the YMCA quite a bit. They have a Silver Sneakers program that's excellent. And often there are physical therapists that can help locally in the community. And then we have a lot of support through Wilmot and other places for healthy eating. There's an integrative oncology clinic at Pluta that will help with looking at diets and other integrative oncology methods to maintain survivorship.
Thank you so much for that comprehensive response to that. And I think this one is for you, Jason. As you referenced the cancer.org website, are those resources available locally?
Yes, cancer.org. Most of our resources are easily printable. You can print them off and use them locally. Our service line is available to patients 24 hours a day, 7 days a week. As we have ACS employees that connect with those patients, and if a lot of at the National Cancer Service Center, we integrate with a lot of community partners in every community across Western New York. So when we do have sister organizations that may have a local program that may be more appropriate for a patient's request, we'll connect them to those as well. But yes, all of our resources are available locally and nationally.
Thank you. Thank you.
Sure.
Dr. Mohile, I think this one is for you. When am I considered cured or cancer-free?
That's a great question. So I think it's very dependent on the cancer and the treatment that's given. What I like to think of cure as not having any recognizable cancer in the body through pictures, or if there's markers for that particular type of cancer. And so often when patients present to an oncologist, there is the ability to cure cancer because of the stage of the cancer or where it is. In other circumstances, there are abilities to provide a remission or to control the cancer, but we won't necessarily be able to get rid of it completely. Those patients are not cured, but can live long and healthy lives, especially now with the sort of explosion of new treatments. And that population also has survivorship concerns and issues because they're actually surviving with cancer and treatment. And in fact, the National Cancer Institute is interested in that group of patients and is developing new research programs and resources for that group. But cure really is when there's no cancer in the body and that we can't see it. There may be a chance for it to come back, and that's why surveillance and survivorship is so important. Doing pictures or markers or exams as per what is defined in guidelines for that particular cancer. But there are patients who are cured after treatment if they've had a curable cancer and then they get the treatment and then it's not there anymore.
Thank you. Thank you. Mr. Coleman, I'm going to pose this one to you. I think you talked a little bit about caregivers. And so as a caregiver, what resources and supports are available for me? And also, what should I provide after treatment has ended?
Yes, so we have a whole section at cancer.org for caregiver resources. And I highlighted the grant application that we're currently involved in now. That's very exciting because that is specific to caregiver respite and offering programs just for caregivers that are going to be offered. We're going to conduct those sessions at our Hope Lodge in Rochester and also virtually to be available throughout our catchment area. So we have, well, I don't think I could probably list them all in the time that we have together, but I encourage you to go to cancer.org and look at our caregiver section and see what's there. But yes, I think that's the best answer I can give.
Thank you. Dr.
Sure.
Mohile, is there anything that you'd like to add to that?
Absolutely. So our program here at Wilmot, so maybe I can say what we do in Wilmot is we're doing research, but we're informed by the community. So the community and why we're here is what comes up on these calls. And when we're in patient groups, we want to hear from you about what is important. And I hear all the time that caregivers tell us that their that they have needs that are not being addressed by the current healthcare system. I hear that in my clinic when I'm taking care of patients. The majority, if we go back to older patients with cancer, the majority of caregivers are older themselves because often they're spouses and they have their own healthcare needs and that they're managing. And it is very stressful to provide caregiving, whoever a caregiver is. And our healthcare system is not good at addressing the needs of caregivers, making sure there's good communication about those needs, and making sure there's support for them. So in our research program, because we've heard this from the community, we are developing research in this area. We actually have quite a few studies that we run through Wilmot proper and also the geriatric oncology clinic, where patients and care partners do interventions together. We call that dyadic, because if you're doing a mental health intervention together, it's more powerful as a team, patient and care partner, than it is to just focus on the patient and not the care partner. Because we know if the care partner is not feeling well, that the patient may be affected by that. And so it's important to address that too. So we're developing supportive care interventions. We have mental health interventions. And a few of our younger researchers are really interested in this. For example, Dr. Lee Kehoe is a mental health counselor who's developing dyadic mental health interventions for patients and care partners with cancer, where they do life review together. And that helps with their mental health. They sort of talk through the things that are happening and provide behavioral therapy to kind of manage and cope with very difficult situations. So it is a need. We wish things were better. I'm not sure there's defined support. We will have support groups, but I don't think there's like a plan to help address mental and physical health and care partners. And that's what our research hopes to remedy.
Thank you. Thank you both for that. I'm going to come back to you again, Dr. Mohile, and the question is, one of your slides talked about introducing people to clinical trials. So how do patients learn about clinical trials, and are there any currently open in our area?
Oh yeah, that's a great question. So Wilmot is a leader in clinical trials in the catchment area. It's a huge strength, and we're very lucky in our community to have this program here. So clinical trials are broken down into different kinds. One of the kinds of clinical trials that's very important is therapeutic clinical trials. These are trials that offer new avenues for treatment or different patterns of treatment that we are learning about. Sometimes they're, very often they're FDA approved treatments already, but we're using them in different combinations or in different ways. And so those clinical trials are very much available through oncologists at Wilmot. If you have a cancer and you're thinking about, is there a clinical trial for the point I am in my cancer treatment, you can be referred to Wilmot and see an oncologist here. Even if you have oncologists in the community, and maybe if there's an open clinical trial, you can enroll on that. And then there's communication with your doctors locally. So that is something that exists. We also have what we call cancer control and care delivery trials and cancer prevention trials. Like Mr. Coleman talked about prevention through the video, how to prevent cancer from developing. There are trials looking at ways to do that, sometimes medicines, sometimes care models. And then for cancer control, it's really symptom management or other kinds of like mental health interventions. And we have those clinical trials also available through Wilmot. So they're in a portfolio. And so any cancer provider usually has access to what's available through Wilmot and can enroll. But if you go to the website, Wilmot has a website that shows all the clinical trials, and you can look for things there, and there is a contact number there. And so you can also reach out if you're interested in specific information about trials.
Thank you so much. Mr. Coleman, this next question is for you. In your presentation, you showed slides about the top cancers in the nation for both men and women. Are there any differences in our region in New York State, or do those numbers bear the same way in our area?
Well, that's a very good question. I mean, I've seen data for county level data across the state, and it looks very similar to what we see there. There's a lot of parallels. If the question, or do we have any hot spots here in our region? I'm not aware of any specific acute areas that that are specific to Monroe County and Western New York.
Thank you. Dr. Mohile, do you have anything to add to that?
Can you repeat the question, Candice? I just want to make sure I'm answering it correctly.
Yes, the question was that in the slides, there was information about the top cancers for men and women across this country, and wanted to know if there were any differences in our region that we should be.
Yeah, there are. So we have looked at that through, actually our community outreach and engagement program has looked at the statistics for what are the most important cancer priorities in our region. And so and the cancer priorities are because of not only the prevalence, but the burden. And so there are a few, so tobacco related cancers are very high in our region. And so that includes thoracic cancers like lung cancer and head and neck cancer, and bladder cancer. So bladder cancer is a tobacco related cancer. So that's very high in our region. Breast cancer is higher in our region. And then leukemia and pancreatic cancer are high in our region. And so that's another, just a point that we actually look at those data through our community outreach and engagement office led by Dr. Cupertino, who informs the researchers about the high prevalence of certain cancers. And we try to guide our research to address the most prevalent and most burdensome cancers in our region.
Thank you. I think we have time for one more question. And the question is, thank you, both Dr. Mohile and Mr. Coleman. My parents, who are both living with cancer in their 80s, do not live in the area, but I found today's discussion very informative as a family member. So thank you very much for that comment. There's one final question that asks, what should I be doing to prevent recurrence of cancer?
Yeah, so I can take that one. Yeah, I wish we had better ways, but really the best ways are to keep on top of surveillance. It's not to, recurrence may happen, but even if it does, knowing when it happens and actually intervening very early can still be very effective and improve your survivorship and longevity. And so it's very important to do the surveillance. But in terms of prevention, the best that we know, and it seems simple and kind of silly, is heart healthy exercise. So the things that are good for your body prevent cancer. So bad things in moderation. So alcohol, don't smoke if you are able to not smoke. Tobacco increases risk of recurrence. Exercise as much as possible. Even if you have disabilities, the more you do, the better your outcomes are. And so sometimes I hear I'm very tired, or I have a knee problem, or I'm not able to get out of a chair. But even if you're moving, increasing steps by just a small prevalence amount, like 10%, that increases outcome. And so those are really the best ways to prevent a recurrence, or the same ways to prevent cancer.
Dr. Mohile, Mr. Coleman, thank you so very much for this discussion today. I want to thank everyone who joined the call, this session on celebrating more birthdays, cancer survivorship in older adults. I also want to thank our interpreters for helping to make this accessible to our deaf community. Please be sure to fill out the survey following this webinar to make sure we are providing the content that you are interested in hearing about. It has been recorded, and an email with a link to the video will be sent to all registrants early next week. I want to thank you all again and encourage you to join us for our next community conversation in August. We will be taking off in July, but our next one will be August 12th with Dr. Patricia Rivera. Thank you all so very much. Have a great weekend.